Thank you, Jean. Thank you for the invitation. I'm very happy to be here. So I will begin the talk by saying a few words about alcoholic hepatitis in general, and after that I will move to the transplantation, which is the let's say, main core of the topic. So first of all, I'd like to say you some words about the diagnosis of alcoholic hepatitis. It's very difficult to diagnose alcoholic hepatitis, in fact, because we have little data about the incidence and the prevalence of the disease, and there are different clinical entities in terms of alcoholic hepatitis and on alcoholic patients. Because if you perform a liver biopsy in a patient who is doing well and who has a heavy alcohol consumption, you will be able to diagnose alcoholic hepatitis in 15 to 20% of cases. That's on, let's say, stable patients. They drink alcohol, but they have no symptoms. And it seems that there might be a small subgroup of patients who are more likely, more prone to develop recurrent episodes of alcoholic hepatitis if they continue their drinking along the time. And in this paper, which has been published by Philip some years ago, it was observed that patients who had hepatitis on the first liver biopsy were more likely to have again alcoholic hepatitis on a second liver biopsy if it is performed 2 years after. And this process might result in an enhanced inflammation and a faster progression to cirrhosis. And on the other hand, you have the clinical presentation of severe alcoholic hepatitis, which generally speaking occurs in the background of a patient who has alcoholic cirrhosis, and at the time of the presentation, there is usually a hepatic decompensation, and the main clinical feature is a recent onset of jaundice, less than 3 months, in the absence of any other cause. The firm diagnosis of alcoholic hepatitis is based on histology and in the combination of balloon hepatocytes infiltrate with neutrophils, marrowy bodies, and a certain degree of fibrosis, cirrhosis, or steatosis. And to firmly establish the diagnosis of alcoholic hepatitis, liver biopsy is required, although it's not so simple to get liver biopsy in some cases. And in the specific field of severe alcoholic hepatitis, a transjugular course is required when considering that almost 70% of patients have ascites, and they also have coagulation disorders, more particularly in terms of platelet count. And to us in France, the diagnosis should be performed using the liver biopsy because we have some data suggesting that the diagnosis of alcoholic hepatitis is not confirmed to 30% of cases of patients admitted with a suspicion of alcoholic hepatitis. These are two studies evaluating the role of liver biopsy for the diagnosis of severe alcoholic hepatitis. The first part of the slide, at the upper part, is from Ireland, from the group of Stephen Stewart. What they did, they made liver biopsies to 58 patients admitted with jaundice and severe liver decompensation, and they observed that among those 58 patients, 15 of them had no alcoholic hepatitis at liver biopsy. And when you compare the differences in terms of clinical but also biological features in these subgroups, there were no difference or little difference between the two groups, meaning that some patients admitted with jaundice with a heavy may have no alcoholic hepatitis. And we have potential confounding factors such as infection, such as hemolysis, especially spur cells, which are frequent in patients with severe cirrhosis. You also have drug toxicity, viral hepatitis, and so on. And the second study evaluated let's say, the prevalence of alcoholic hepatitis in patients admitted with recent jaundice. This is from Rajiv Jalan's group in London. He performed liver biopsy in 68 patients admitted again with an acute deterioration of liver function, and only half of them, roughly, had alcoholic hepatitis. So if this is possible, my feeling is that it could be better to diagnose firmly alcoholic hepatitis by performing a liver biopsy in patients with such a suspected diagnosis. There are also other advantages of performing liver biopsy in those patients. Of course, it enables a definite diagnosis of alcoholic hepatitis, but it also helps in assessing the prognosis.
I have a question here.
Yes, sure.
I'm sorry, I wanted to see what's your take on the white blood cell count.
Yes.
WBC.
It's a complex issue because, you know, we have not published those data so far, but we try to evaluate in our cohort in Lille if the number of white cells in the blood are correlated or not with the fact of having neutrophil in the liver. And we found no correlation at all. And there are also other unpublished data which call that point into question. So it's not so, let's say, not so firm in terms of biological tool to diagnose alcoholic hepatitis. And I will say a few words about the issue of infection after that. But it's very difficult to interpret the white blood cell count in some situation of a patient who has indeed alcoholic hepatitis, but who is also admitted with sepsis, even if sepsis is not a very marked sepsis. And in this situation, the interpretation of white blood cells, it's very difficult. So I wouldn't go to say that it's a good tool. We need confirmation. My feeling is that those data are too preliminary.
Why is the AST missing from that?
There, sorry?
The AST.
So the AST is also a complex issue because in this situation, in this paper, there was no difference between patients who have alcoholic hepatitis and those who haven't. What is very important to keep in mind is that when considering the AST level in patients who have alcoholic liver disease, it's very different as compared to viral hepatitis, autoimmune hepatitis, and so on, in which the level of transaminases is higher. So many patients have a florid alcoholic hepatitis at liver biopsy and have a low transaminases level. And there is no correlation, again, between AST level and the degree of inflammatory infiltrate in the liver. So again, I don't think it's a good tool to diagnose alcoholic hepatitis.
So then the 2-to-1 AST-ALT ratio that we see in patients with alcohol liver
Yes.
disease, is that kind of reversed or not actually true when they actually have alcohol hepatitis? Would that be accurate?
It's complex because in any chronic liver disease, once you have cirrhosis, the ratio between AST and ALT is generally greater than 1. Even if you have NASH, even if you have HCV virus infection and so on. So it's probably not such a good tool. Another point which is important to me is that AST grows up when hemolysis is present due to the isoform which is located in the red cells. So in patients who have a small part of hemolysis on the background of liver cirrhosis and of alcoholic hepatitis, AST level was very high. So again, it lacks specificity, in fact. So in terms of biopsy, this is a paper from the group of Ramon Batalier, and what they did in this collaborative paper was to try to link some histological features with the outcome of patients at time of liver biopsy, that is, before the treatment is started. And what Ramon showed in this paper is that the presence of cirrhosis, the bilirubinostasis, the lack of neutrophil infiltration, and the absence of megamitochondria were linked with outcome. and they built up a score in which the higher the score is, the poorer the prognosis is, and this has been confirmed. This is the generation cohort, and this is the validation cohort. And on that sample of patients, the liver biopsy to evaluate the prognosis is confirmed. But again, this is only on baseline histology. It does not take treatment effect into account. If you have no way to get liver biopsy in your patient admitted with severe alcoholic hepatitis, that's the case in some centers or in some countries, I would like to remind you that this paper, which has been published last year in Gastro, and which came from different experts in the field of alcoholic hepatitis, had set a classification on definite, probable, or possible alcoholic hepatitis based on histology, but also on biology and clinical features. So if you have no access to liver biopsy, this is also a way to try to confirm alcoholic hepatitis in a patient hospitalized with decompensated cirrhosis. We lack biomarkers, unfortunately, but it is changing. This paper is from Pierre-Emmanuel Routou's group in Beaujon Hospital in Paris. They try to evaluate whether the level of cytokeratin 18 was associated or not with the fact of having alcoholic hepatitis at liver biopsy. It's difficult to evaluate a firm cutoff for the moment, but as you can see, regardless of the cohort, it seemed that patients with alcoholic hepatitis had a higher level of M65 or M30. This deserves future validation, of course. This is based on liver biopsy, but this may avoid the realization of liver biopsies in some patients if it is confirmed. Generally speaking, an ideal diagnostic marker for alcoholic hepatitis should fulfill all these items. To me, it must be simple. It must be performed in routine practice, and certainly be based on serum assessment, because otherwise it will be too complex for several teams, especially for those who have not large technical possibility to have biopsies, complex biological dosages, and so on. But it needs further validation, of course. So once you have diagnosed alcoholic hepatitis, it's crucial to evaluate its severity, because patients who have severe alcoholic hepatitis require specific treatment, whereas patients who have non-severe alcoholic hepatitis only need, let's say, addiction support and alcohol cessation. I will be brief on the Madrid story, but that's one of the most important steps in the field of alcoholic hepatitis. The score was developed when I was born, in fact, in 1978. And Dr. Madrid did a really great job because his conclusions are still valid now. So the score, as you know, is based on coagulation disorders and on the bilirubin level. And according to the cutoff of 32, you're able to distinguish patients who have severe alcoholic hepatitis, who do not so good after a short period of time, this is 28 days, as compared to patients without severe alcoholic hepatitis, who have, let's say, rather good outcome after a short period of time. But as you can see, the mortality is not zero. So some patients without severe alcoholic hepatitis still die. So the Madrid scoring system is certainly the best one, or one of the best ones, but other scoring systems might be used. This is the data from the Mayo Clinic testing the MELD score in this situation. It's difficult to, let's say, firmly set a cutoff for the MELD score. It's certainly between 19 and 21. But as you can see, the ability of the MELD score to determine the prognosis of patients admitted with alcoholic hepatitis seemed to be better in that paper as compared to the Madrid function. In our hands, MELD score and Madrid function work the same in terms of prediction of prognosis of patients with alcoholic hepatitis. You may also use the Glasgow alcoholic hepatitis score, which is more complex based on leukocytes counts, urea level, bilirubin, coagulation disorders, and I don't remember the fifth. But anyway, according to the cutoff of 9, patients who require pharmacological treatment are here with a score greater than 9, and these are patients without severe alcoholic hepatitis based on that cutoff. And you can also use the score by Ramon Batalha's group. This is the ABIC scoring system, which includes age, bilirubin, INR, and creatinine. That's the acronym of the score. And the cutoff in this situation are 6.71. This is the cutoff associated with no mortality after a short period of time, as compared to the 9 cutoff, which is associated with a bad outcome. Regardless of the scoring system you use, if you have diagnosed severe alcoholic hepatitis, it requires a specific pharmacological treatment with many potential targets for treatment. And I have to say that so far only prednisolone has shown its efficacy in this setting. But there is a lot of research performed in the field for apoptosis, for the oxidant level, for the regeneration, for the fibrosis. I won't speak about fibrosis here, but this is certainly a very interesting issue, especially for patients with early steps of alcoholic liver disease. So all these parameters will be assessed, are assessed at the moment in the specific setting of alcoholic hepatitis. One of the facts which explain why we only have prednisolone for treating severe alcoholic hepatitis is that, as compared to other fields in hepatology, we have no good animal model to model alcoholic hepatitis occurring at the background of alcoholic cirrhosis in mice. Because if you feed mice with alcohol, you have steatosis, you have inflammation, let's say a kind of inflammation in some situations, but you have very little fibrosis. So we have no good model which is able to recapitulate all the histological features and the clinical features, including encephalopathy and ascites, which are observed in patients. This is why translational research is important. This is an example, but we have many good papers based on translational research in alcoholic hepatitis. This is based on chemokines, that's part of Ramon Batalha's group again, showing that FN14, which is a parameter associated with liver regeneration in alcoholic hepatitis, is associated with the outcome. And it also certainly plays a role in the pathophysiology, and it could perhaps be targeted in future treatments for alcoholic hepatitis. So my feeling is that the ideal approach to try to evaluate new molecules in the field of alcoholic hepatitis should be based on translational research with, after that, a certain degree of confirmation in mice if possible. But we also have to go from phase 1 to phase 2 on phase 3 studies, because it's certainly very difficult to prove the efficacy of any molecule by beginning directly in a phase 3 study, because the tolerance of the molecule might be not so good. Many patients have kidney failure, they all have liver failure, so pharmacokinetics are very important in this setting. So, prednisolone. Prednisolone is a controversial treatment. It should not, to me, because we have conflicting data for, let's say, 4 decades, suggesting that it works or it doesn't work, and so on. We have now robust and reproducible data which confirm that it works versus placebo in terms of short-term mortality. It improves the 28-day mortality. We have a huge amount of data regarding this, but it's not an ideal drug. As an example, prednisolone does not impact 3 months or 6 months mortality. So I'm not saying that's the ideal treatment, it's not, but it works. So we must make progresses in terms of new treatments, in terms of new strategies in these patients, and I think we should stop the controversy of whether it works, doesn't work. We should focus on new molecules and on new drugs. So this is, for instance, the meta-analysis which had been published by Philippe 6 years ago. We have now new data. It improves short-term survival. Unfortunately, the combination of molecules, an acetylcysteine, for instance, or pentoxifylline, for instance, too, does not add to prednisolone alone. Because this is the paper on the left part of the slide by Eric and Nguyen Kak, published 6 years ago in the New England Journal of Medicine. There was no improvement in survival. The study is negative, and by the way, the control arm, which is in red, did very poor as compared to historical cohorts. So it should perhaps have been somewhere between the two curves. So the study is negative, unfortunately. On the other hand, that's the right part of the slide. This is the STOPAH study. That's based on the factorial design with prednisolone, placebo, and pentoxifylline. Pentoxifylline doesn't work alone or in combination with prednisolone, whereas there was an increase in short-term survival with prednisolone, which disappears again over the time, along with the possibility of the patient to relapse to heavy alcohol drinking. But I will tell you a few words about this later on.
Alex,
Yeah, sure.
if you go to the previous slide,
Yeah.
I'm a little surprised that you think of the Nguyen study as being negative.
Yeah.
Because one of its unfortunate historical things is that it came 4 years before the STOPAH trial, right?
Yeah.
And so the STOPAH trial really looked at 28-day survival as the sort of primary improvement in survival. Then you could argue that the primary endpoint in the Nguyen study should have been 28 days, 3 months, although that
It was 6 months, yeah.
right.
In fact, the study...
28-day survival, though, was statistically significant.
Yes.
Survival.
Yes, yeah, you're totally right. In fact, the sample size was calculated based on 6 months survival, which, let's say, can be discussed because the endpoint is very far from the end of treatment. So it's probably not the ideal way to evaluate. But to me, again, and I had this discussion with Eric and Nguyen Kak. The main problem of that study is that the control arm registered a high number of deaths within the first period of time. Because, as you can see, generally speaking, based on the inclusion and exclusion criteria, the 28-day survival should have been between 80 and 85%. And as you can see in here, it's close to 62%. So my explanation, I'm not saying I'm right, but my explanation is that, in fact, when you have a look at the survival curve of the combination arm, it resembles what we have in patients who are treated with prednisolone alone. So the trend towards significance at the end of the trial after 6 months, to me, is mainly based on the fact that mortality was higher in the control group in this situation. I cannot prove it, of course. What can perhaps be an explanation is that in the prednisolone plus an acetylcysteine group, patients got a perfusion of an acetylcysteine, so they got a kind of fluid expansion as compared to patients who had only the placebo. Because patients, plus prednisolone, because patients who had prednisolone alone only got prednisolone in an oral course, and they, oops. Remind me later. So it can be one explanation why the difference is, let's say, observed after a short period of time. And we have also other data coming from other groups, especially from India, but also from Europe, suggesting that the combination of an acetylcysteine plus prednisolone doesn't work.
Please comment on the design of the STOPAH trial, because obviously they didn't do biopsy, but
yes.
The question is it practical to biopsy 1,100 patients, and what do you think about all of these patients came to the study?
Oh, it's a complex issue. To me, if you perform a phase 3 trial, liver biopsy should be performed, especially when considering that most centers who were involved in the STOPAH trial had the availability of liver biopsy in their centers. So I think that I fully agree with the fact that it's impossible to do liver biopsy for all patients suffering from alcoholic hepatitis in France, in the UK, in the US. It's obvious. But at least in a randomized clinical control trial, I would certainly go to liver biopsy. In this paper, if I'm correct, there were only 28% of patients who had alcoholic hepatitis, which was biopsy proven, meaning that 72% of patients had no confirmation of alcoholic hepatitis. And my feeling is that, it's my personal feeling, again, I'm not saying I'm right, is that patients were included in the trial without alcoholic hepatitis with, let's say, only decompensated blank cirrhosis without post-alcoholic hepatitis. Another issue which is, let's say, which might be discussed at least in this paper is that, I will say a few words about this later on, is that there was no systematic screening of infection. And I fear some patients with active infection were included in the trial, but I will have a slide about this later on. So these are the very recent data based on almost 2,000 patients from 7 randomized controlled trials, confirming again the impact of prednisolone in alcoholic hepatitis. But again, no difference in 3 months or 6 months survival. So again, it's not an ideal drug. So patients will take benefit from the molecule, but some will don't. And it's very crucial to identify early on which patient will take any benefit of prednisolone if they suffer from alcoholic hepatitis as compared to those who don't. And you have several tools to try to define a response to treatment. This is the Lille model, and it was published 10 years ago now. This model is, formula is complex, but it's available online. It's based on age, difference in bilirubin within the first week of treatment, albumin, coagulation disorders, bilirubin, and renal failure. And according to the ideal cutoff of 0.45, you're able to classify patients in responders who have a low Lille score and who do well after a short period of time, as compared to non-responders who prednisolone, who have a very high Lille score and who are unfortunately likely to die after a short period of time. This model also works in pentoxifylline-treated patients, in placebo-treated patients, but also in the combination of prednisolone with pentoxifylline. And it's also possible to refine the prediction of outcome in patients treated with prednisolone in this setting based on the cutoffs of the Lille model. That's what was done in Philip's paper. That's the meta-analysis. That's the complete responders. These are patients treated with prednisolone. These are the placebo group. Certain difference in survival. That's the partial responders. And these are the non-responders, the null responders, according to the, oh, sorry, it's a mistake, it's 0.56. And it's, in this situation, patients do bad if they're treated with prednisolone or if they're treated with placebo. So our recommendation is that if after the first week a patient has a Lille score greater than 56, prednisolone can be stopped, because the evolution will be the same if it's treated with prednisolone or with placebo. So in this situation, we stop steroids in those patients. And it's also possible to refine the prediction again based on the information from the Lille model and from a, let's say, static model, which is calculated at baseline. This is the x-axis, that's the Lille model from 0 to 1. And this is the y-axis when patients who is admitted with a MEL score, for instance, of 21 is here. So if you combine the information from the two scoring systems, you're able to evaluate this is the probability of dying at 6 months. And if a patient is here, he's admitted with a MEL score of 21, and if his Lille score after 7 days is 0.45, the probability of dying is 23% at 6 months. So it's interesting in terms of evaluation of the outcome, so as to discuss, for instance, the possibility of going to liver transplantation. I'll be brief on this, but just a few words about infection, which is an issue in patients with severe alcoholic hepatitis. This is the incidence and the prevalence at baseline based on all these papers, which are randomized controlled trials or cohort studies. So it's frequent, from 6 to 30% of cases. And in a prospective study in which we recorded all infectious events occurring in patients admitted with alcoholic hepatitis, we observed that about 25% of patients are admitted with infection, symptomatic or not. And in this situation, SVP was the most frequent event together with bacteremia. We had a small number of cases of lung infection. And if the infection is diagnosed, thanks to their systematic screening, and if it is treated with antibiotics, the evolution is quite good. These are the survival curves, and as you can see, there is no difference between patients not infected before the initiation of prednisolone versus patients who had infection, who were treated with antibiotics, and after that, who received prednisolone. So, to me, it's very important to perform such a screening before going to prednisolone, and I suggest using the following screening methods. Another issue, yes?
Would you wait for the blood cultures to result after 48 hours before starting?
Yes, generally speaking, yes. We wait because when the patient is admitted, we perform the liver biopsy within the 3 first days, I would say. We perform the infection screening, and once we have all results of liver biopsy and results of the infection screening, after that we go to prednisolone. We are in a university hospital. It can be easier as compared to other hospitals, especially in France. That's different for infection occurring after the initiation of prednisolone. As you can see here, the prevalence of lung infection is far higher, and the median time for infection in this situation was 2 weeks. And when you have a look at the pattern of patients who develop infection, it is mainly non-responders to prednisolone who have still an impaired liver function. And when you have a look on the multivariate analysis, the infection is not associated with short-term survival, meaning that there is a strong link between response to treatment assessed by the Lille model, severity of the disease at baseline, and infection. That's why perhaps infection does not seem to have an independent role. But I have to say that this is, again, patients not infected, patients infected, but in this situation we have many non-responders, again. As you can see, no difference between responders and non-responders to prednisolone according to the incidence of infection, but in the small group of responders who will develop infection, the outcome is not so good. So we must have a look more precisely on this situation, and antibiotic prophylaxis might be interesting in this setting. Same data from the STOPAH trial, high incidence of infection if the systematic screening is applied. Patients had to be stabilized for at least 7 days in case of patent infection, and as you can see, it seemed that patients treated with prednisolone were more likely to develop infection, but also to die from infection. But again, My feeling is that if some patients had asymptomatic infection and received prednisolone, it's bad news. So I don't know to which extent the systematic screening may have avoided such an evolution. But again, to me, infection screening is mandatory.
Can you describe the lung infections in a little more detail? Did they seem to be hospital-acquired or community-acquired pneumonia?
Unfortunately, I have no data regarding the STOPAH trial data. But in our cohort, we had, let's say, mixed patterns. Generally speaking, pneumonia occurred 2 weeks after the initiation of prednisolone, and in the subgroup of patients who were non-responders to treatment, it means that it occurred 7 days after prednisolone was stopped. So I'm not saying, of course, that prednisolone has no role in pneumonia, but we observed pneumonias and very severe pneumonias, sometimes very far from the end of treatment. So it may be that very severe lung infections are related to a very severe liver failure. And I have also to say that in infections occurring before the initiation of prednisolone, we had cases of aspergillosis and of pneumocystis pneumonias. So the link between liver failure and opportunistic infections seem to be present. But again, I'm not saying that prednisolone has no role in it.
Do you think there's a role for prophylactic?
I don't know.
Antifungals and
we are conducting a study with antibiotics with clavulanate and amoxicillin in France. The trial is ongoing, and in fact, we hope that patients who will receive the antibiotics are given together with prednisolone along the first month of treatment. We hope that the incidence of infection will be lower in the antibiotic treated group. But so far I have no data. But it's a crucial issue, of course, you're right.
And just one last question. Do you know to what extent when the lung infection becomes severe, is it a worsening of a commensal bacterial infection?
I don't know. I don't know. It's a very good point. It's a very good point. It's very difficult to address this issue because, contrary to SBP or to bacteremia, it's very difficult to prove the infection, to identify the bacteria which is responsible for lung infection. So it's a very complex issue. My feeling is that a small subgroup of them have very resistant bacteria, but I don't know if the infection occurs in the background of a multi-resistant bacteria which is here for, let's say, weeks, especially in patients who are hospitalized, or if it's the liver failure, the potential antibiotics given 2 weeks before and so on, which resulted in the selection of a high resistance bacteria. I don't know, but this is crucial. So I'll be brief on this, but this is the paper again from the Markers group, suggesting that the dosing of bacterial DNA could be interesting to separate patients who will develop infection from those who don't. But the meta-analysis regarding the issue of the promotion of infection by prednisolone in this setting is negative, meaning that patients who are treated with prednisolone do not have an enhanced prevalence of infection as compared to patients who receive placebo. But again, one should be cautious because we have many old studies included in this meta-analysis. So what is the ideal treatment for non-responders? It's very complex because, as you have seen, they are very likely to die. MAR system doesn't work, methoxyphylline doesn't work, and we think those patients are in a kind of therapeutic dead end. So this, in fact, explains why Philippe proposed to perform the study on liver transplantation in a very selected subgroup of them. The problem is that we know that in alcoholic cirrhosis, alcohol cessation helps the liver regenerate and helps the liver function be better. But unfortunately, as you can see from this study from Rennes in France. In fact, about 50% of patients admitted with a decompensated cirrhosis improve along the time. However, 2 to 3 months is too long in many patients with severe alcoholic hepatitis, because this is, these are unpublished data from our group. In the subgroup of patients with a very severe liver dysfunction, who have a high resistant alcoholic hepatitis, median time to death is close to 1 month. So it's unfair to say to a patient, okay, we will wait for the improvement with alcohol cessation, because the patient will die. So that's why the French consensus states it's unfair for non-responders to wait, because they will be dying, and it recommended pilot studies to evaluate this procedure. Of course, it challenges the 6-month rule, but it's not a good rule at all. It's, let's say, specific, but it's not sensitive enough. These are 2 papers from Di Martini, published 11 years ago, and from Foster, published 12 years ago, showing that these are the 2 RAC curves, not very good in fact, to predict alcohol relapse after liver transplantation. And as you can see in this paper from Foster, more than 50% of non-abstinent patients before liver transplantation were abstinent after it. So we need to have data to evaluate which patient is susceptible to reach abstinence after liver transplantation, and it's not so simple to predict, in fact. So this is the pilot study, published 6 years ago by Philippe and all the French centers involved in the program. 26 patients from 7 centers. These are patients transplanted for severe alcoholic hepatitis, not responding to medical treatment, who experienced their first liver decompensation, and none of them was aware of the diagnosis of underlying cirrhosis. This was an entry criterion for the study, for the program. The survival is far better as compared to patients who were matched based on severe alcoholic hepatitis, who got no liver graft, no liver transplant. And liver transplantation shifts, in fact, the outcome of patients with non-responsive alcoholic hepatitis to that of responders, in fact. So it's interesting in terms of survival. All patients had a very severe liver decompensation at time of transplantation. MELD score, for instance, was 34. And I have to say that in France, we have no specific alcoholic hepatitis indication to be listed, and patients are considered as having an end-stage alcoholic liver disease. There is no abstinence duration required in France versus other systems, I would say, in Europe. And I have also to say, but we might discuss this later, that we observe a kind of learning curve in terms of identification of patients. We need a consensus. It was not so simple to set, but to be selected, any patients who had alcoholic hepatitis not responding to medical therapy had to, let's say, convince all circles from the nurse, specialists in addiction, hepatology team, and transplant team as well, to be put on the waiting list. But I also have to say that we have at that time no firm definition of how the consensus should be in the pilot study, and we're working on that in a new program, which I will be talking about later. Alcohol relapse, none of them was observed in the first 6 months, and 3 patients relapsed during the follow-up. And despite an appropriate management, 2 patients were still alcohol consumers, daily consumers. In terms of impact on the waiting list, less than 2% of patients admitted with severe alcoholic hepatitis were transplanted. It's crucial. We must evaluate the impact of this procedure on our waiting list, generally speaking. Are these data confirmed? Yes and no. In terms of survival, yes. These are two retrospective studies coming from the US, and the diagnosis of alcoholic hepatitis was made on the explant, but transplantation in these two papers was not made in intention to treat. So the discovery, let's say, of alcoholic hepatitis was made on the explant. So patient was not put on the waiting list because of alcoholic hepatitis. We also have data from the UNOS database published by Ashwani Singhal 6 years ago. Good results, no difference between alcoholic hepatitis and alcoholic cirrhosis, and the outcome for the graft was the same. At that time, alcoholic hepatitis was defined at time of listing, which is different. It's encouraging data. And of course, these are genes data from Mount Sinai Hospital. Very good impact of liver transplantation on short-term survival in those 9 patients who were included in the study. Very encouraging again. And these are the data from Baltimore, published by Dr. Lee this year in Annals of Surgery, compared to alcoholic cirrhosis with a 6 months abstinence rule, no difference in survival after a reasonable period of time. So encouraging again. And the accelerated consumption also observed very good survival results, with at 3 years more than 90% of survival after liver transplantation. And as you can see, the indication of early liver transplantation for alcoholic hepatitis in the US is increasing over the time since the New England Journal paper, perhaps, I don't know. So the activity is growing, and we must evaluate the impact on the waiting list again. So this is the ongoing study in France, the QuickTrans study, which was supported by the French Ministry of Health. These are the number of patients included, 77 and 98. This is the comparator, patients with decompensated cirrhosis with a period of abstinence of more than 6 months. It's not the ideal rule, again, but that's the only we have. Their results are expected for next year, and the selection, in contrary to what was done in the pilot study, was based on, again, first liver decompensation and absence of severe comorbidities, but we included an algorithm based on family support, of psychiatric evaluation, the willingness to quit alcohol, but also a subjective evaluation by the medical team. So that program will also assess whether this algorithm helps identify patients who will not develop a relapse after liver transplantation. So that's the very, very preliminary results. It's based on the recording on each center. So I cannot say this is exhaustive, but we have the same number of relapses in the 2 groups, although more patients with alcoholic cirrhosis were transplanted as compared to patients transplanted for alcoholic hepatitis. It seems that among all the relapse, half of them are heavy relapse and half of them are occasional relapse, because these data are only for any kind of relapse, including SLIPs. And in the group C, which included patients with severe alcoholic hepatitis, not responding to medical treatment without liver transplantation, not surprisingly, many deaths occurs. If you're interested on the ethical consideration of transplantation for alcoholic hepatitis, I do suggest reading this editorial published in Journal of Hepatology, published by Christophe Moreno and colleagues. It's a very interesting paper. I have no time, unfortunately, to discuss the paper in details, but if you're interested in ethics, it's quite interesting to read. So, the selection of a patient for alcoholic hepatitis is challenging, in fact. This is a paper published 6 years ago. It's a prospective evaluation of transplant centers across the US. And it's interesting to note that the author found in that paper that the consensus was not so simple to define, in fact. There is judgment which can be considered as inconsistent within the committees. And it also seems that some, let's say, expert members could be outside of their expertise in some situation, especially in terms of addiction. My feeling is that to qualify a patient for such a program, it's very important to have the opinion of an addiction specialist and a surgeon and a hepatologist and a nurse and, if possible, a general practitioner. It's a very difficult decision to take, so it's important to get the benefit of the expertise of each physician and of each medical professional to reach the final decision. And not surprisingly, in that paper, the alcoholic patients pose the most difficult dilemmas. What does the general public think? Complex issue again. I'll be brief on this. It's based on an online survey published 2 years ago. But in fact, the general public seems less reluctant than expected in that paper, because more than 80% of them felt at least neutral toward an early liver transplantation for patients who were still drinking before the admission for severe alcoholic hepatitis. And not surprisingly, the good social support and the financial stability are important in this paper. So alcohol relapse, that's, let's say, the central part of the problem. This is not in transplantation. This is in patients admitted with alcoholic hepatitis who were followed up. 1/3 of them experienced alcohol relapse within the first 3 years. That's generally speaking. And it impacts outcome. It does not impact the very short-term outcome, the first month, say 3 months, but after that it has an impact. And there is an impact in terms of mortality according to the quantity of alcohol you drink. So it's best to recommend complete alcohol cessation, of course. This study confirms this. And this is also confirmed by the group of Ramon Batalier in a study which is in press in hepatology, in which complete abstinence is associated, of course, with a good outcome after first hospitalization for alcoholic hepatitis. In terms of relapse after liver transplantation, it does not seem that excess alcohol impacts the very short-term outcome. This is a paper from Montpellier, from the group of Georges Pajot. He observed that patients who drank excessively after liver transplantation had no impact in short term, but the impact was impressive after 5 years. And this is important because we have very little data about how patients behave 5 years after liver transplantation for severe alcoholic hepatitis. So we must gather those data. In this situation, this was observed for alcoholic hepatitis patients, alcoholic cirrhosis patients, but also for patients who had a non-alcoholic liver disease indication for liver transplantations. Very important to keep that in mind. The pattern is different. Of course, we had more heavy drinkers in patients transplanted for alcoholic cirrhosis as compared to the other indications. Similar results from the Quadrado paper published 12 years ago. The impact seems to start after 5 years, so long-term data are needed. The group of Michael Lucy showing that alcohol relapse impairs the graft function and is responsible for steatosis, fibrosis, and let's say not so good evolution of the liver. And this is also confirmed by the French groups, Jérôme Dumortier and colleagues, showing that some patients develop recurrent alcoholic cirrhosis on the graft if they continue their drinking after liver transplantation, and this also results in a poor survival. So all these factors of relapse are shown to be predictive factors of cirrhosis, alcohol abuse, and so on. But to date, we have very little data in the field of alcoholic hepatitis, so we must continue to work on those issues. I will end by saying a few words about alcohol trajectories after liver transplantation. The paper of Di Martini showed that very nicely. We have different patterns in terms of alcohol relapse after liver transplantation, so it's very important to work together with an addiction specialist, because in alcoholic hepatitis we have no data, and we must have further data regarding this. And it seemed that some parameters, such as the fact of having relatives consuming alcohol or having problems with drug abuse or DUI in the past, may be linked to the relapse after alcohol cessation. And for severe alcoholic hepatitis, again, data from the US. These are this is the incidence of alcohol relapse in the paper by Lee. But what is more interesting to me, again, same pattern, let's say, of incidence of alcohol relapse after liver transplantation for alcoholic hepatitis. But to me, in fact, we must stick to the predictors of alcohol relapse after liver transplantation. Without liver transplantation, a younger age and the lack of a prior alcohol treatment seems to be correlated with alcohol relapse. And more data are needed in alcoholic hepatitis, but from the Accelerate Consortium, all these parameters seem to be linked to relapse after liver transplantation. So we must work on this. This is from the Accelerate Consortium published this year at the ILTS meeting. And data from here show that some parameters, such as the insight into alcoholism, such as the good social support, such as the history of the patient, must be looked very carefully at to identify and to qualify the patient for liver transplantation. So it is a very new area of research. We all have to work on this and gather data from the US, from Europe, from India, and so on, to identify the good parameters susceptible to identify a patient at risk of liver transplantation to adapt the management. So finally, should we favor a broader use of transplantation in severe alcoholic hepatitis? I don't know, because we must assess the impact on the waiting list. I'm not sure that the available data reflect the real life, because it's based on very expert teams. And again, alcohol is viewed differently across the different countries. These are the unsettled issues. So all patients are not the same. Should we manage them differently? Certainly. I don't know which level of alcohol consumption is acceptable after transplantation. Is 1 glass a year acceptable or not? I don't know. In ALD patients, generally speaking, in alcoholic hepatitis patients, I don't know. But in non-ALD patients, what is the, let's say, maximum alcohol consumption which is acceptable in patients transplanted for HCV? I don't know. And we don't know if the pharmacological agents are useful. So this is my conclusion. I would say that we have growing evidence supporting the early liver transplantation for patients with severe alcoholic hepatitis who do not respond to medical treatment. We need further data to confirm this indication as well as the impact on the waiting list. But if I had only one message to tell you today, is that we must have addiction data. We must keep on working with addiction specialists. And of course, the issue of the long-term outcome is still unsettled. I'd like to end by thanking all the collaborators of the Philippe Mathurin's group in Lille, addiction specialists, hepatologists, and so on. And I thank you for your attention. Thank you very much.